Hepatitis. It's inflammation of the liver. Etiology: infectious and non-infectious. Non-infectious such as alcohol, DDT, halothane, paracetamol, INH. Infectious: viral and non-viral. Non-viral: malaria, leptospirosis, brucellosis. Viral: we have the major hepatitis viruses A, B, C, D, E, recently F and G, other viruses such as Epstein-Barr virus, cytomegalovirus, and herpes simplex virus. If we're going to compare between the 5 major hepatitis viruses, viral genome, they are all RNA except for B, it's DNA. Transmission: A and E are fecal-oral, while B, C, D are common in parenteral and sexual transmission. While B, we can add bodily fluids such as serum, saliva, and transplacental transmission. Incubation period for A and E, it's 2 to 6 weeks, while for the rest it's 2 to 6 months. Mortality rate for A, B, and E, it's 1%, while in E, in pregnant women, it's 20%, in D, up to 10%, and C, 0.1%. Chronicity: it's absent in A and E, while in B it's from 5 to 10%, while in children 90%, in C up to 85%, and D 50%. Malignancy is absent in A and E, but it's present in B, C, and D. Prophylaxis: it's absent in C and E, while in B it's specific immunoglobulins with vaccine 1 and 6 months. A, we have Havrix vaccine and non-specific immunoglobulins. D, we have vaccination against hepatitis B virus because it's incomplete virus with hepatitis B surface antigen code. Pathology: hepatic pathology and extrahepatic pathology. Extrahepatic: splenomegaly, lymphadenopathy, vasculitis, nephritis, bone marrow depression, arthritis. Hepatic pathology: we have portal tract infiltration with inflammatory cells, centrizonal necrosis, and central cholestasis. Healthy framework: clinical picture of acute hepatitis: we have non-ecteric hepatitis and ecteric hepatitis. Non-ecteric hepatitis is the mild form of hepatitis without jaundice. Serum bilirubin is less than 2.5 mg%. Clinically, it presents by influenza-like symptoms, fahem, fever, anorexia, headache, malaise, so it's usually misdiagnosed. Fate of non-ecteric hepatitis: resolution or chronic hepatitis, cryptogenic cirrhosis. Ecteric hepatitis: it passes through 3 stages: pre-ecteric, ecteric, and post-ecteric. Pre-ecteric stage: viremia from 3 to 10 days, acute onset of fever with relative bradycardia, headache, malaise, anorexia, and there be nausea and vomiting. Anorexia is marked against smoking and alcohol. Dull aching pain in right hypochondrium because the liver is enlarged and tender. Then we have the ecteric stage, 2 to 4 weeks. Jaundice appears with improvement of general conditions, so we have decreased fever, headache, malaise, and anorexia. Dark urine, pale stool, and then scleral ectris. Jaundice is due to swelling of hepatocytes leading to obliteration of bile canaliculi. Liver is enlarged, tender, soft. Spleen is mildly enlarged, just palpable spleen. Lymph nodes are slightly enlarged. We have cervical enlarged lymph nodes. May occur in about 10% of the cases. Differential diagnosis for just palpable spleen: typhoid, malaria, subacute bacterial endocarditis, hepatitis, Graves' disease, and infectious mononucleosis. Post-ecteric or convalescence stage, 3 to 6 months. Symptoms and signs gradually disappear. Serum bilirubin decreases, but jaundice is still present for some time because the bilirubin has high affinity to collagen elastic fibers, especially in the sclera. Within 3 to 6 months, patients become clinically and biochemically free. Sequelae of hepatitis: complete recovery or complications. Complete recovery occurs in all cases of hepatitis A and E, many cases of hepatitis B, and few cases of hepatitis C. Complications: we have 6 items: relapse, acute fulminant hepatitis, prolonged cholestasis, post-hepatitis syndrome, chronic complications, and extrahepatic complications. Chronic complications occur with hepatitis B, C, and D. We have carrier, positive markers with negative enzymes, cancer, cirrhosis, and chronic hepatitis. Post-hepatitis syndrome: it may be psychic. The patient is still complaining of the fahem symptoms with pain in the right hypochondrium after recovery. Liver function tests and liver biopsy are normal, but transaminases may be raised. We have transaminitis. Then we have prolonged cholestasis due to unresolved edema of hepatocytes, closed bile canaliculi. Jaundice becomes more deep with pruritus. This condition resolves within 8 to 28 weeks and may occur especially with hepatitis A virus. Relapse, clinical or biochemical relapse. Acute fulminant hepatitis: it's a rare condition where there is rapid development of fulminant acute hepatic failure. Encephalopathy with coagulopathy may develop so rapidly jaundice would be not apparent, so the condition may be misdiagnosed as encephalitis. Then we have the extrahepatic complications or immune complex manifestations. Hematological, we have lymphoma, increased incidence of B-cell lymphoma in patients with hepatitis C. So lymphadenopathy and unexplained chronic anemia in a patient with hepatitis C, it should raise the possibility of lymphoma. Then we have essential mixed cryoglobulinemia, EMC, medical condition in which there is large amounts of cryoglobulins in blood, proteins which become insoluble in reduced temperatures. Hepatitis C can be found in 95% of all cases with EMC. Clinical picture, rash, arthralgia, splenomegaly with muscle weakness, interference lead to symptomatic improvement of both the rash and the joint pain. Renal, we have membranoproliferative glomerulonephritis. Dermatological, lichen planus, chronic mucocutaneous disease affecting skin, tongue, and oral mucosa. Porphyria cutanea tarda, due to reduced level of enzymes responsible for the fifth step in heme production, it will lead to apparent porphyria cutanea tarda, which is the most common form of porphyria. Endocrine disorders, hepatitis C increases the incidence of type 2 diabetes by 3 times, thyroid dysfunction due to increased antithyroid antibodies, eye, uveitis, chronic ulcer, neurological, encephalitis, encephalomyelitis, peripheral neuropathy, especially mononeuropathy multiplex, others, sialadenitis, inflammation of salivary glands, polyarthritis nodosa, especially with hepatitis B, pancreatitis, and idiopathic pulmonary fibrosis. Investigations, urine analysis, stool analysis, CBC, abdominal ultrasound with lifts or liver function test, and finally hepatitis markers. Urine analysis, bedside test, dark frothy urine due to early appearance of bilirubin and bile salts. Urobilinogen level is variable. Stool analysis, we have reduced stercobilinogen, pale stool with steatorrhea. Blood picture, leukopenia with relative lymphocytosis due to bone marrow depression. Abdominal ultrasound, diffuse hepatomegaly. Liver function tests, ALT and AST dramatically elevated. Serum bilirubin is elevated, direct and indirect. Alkaline phosphatase, moderate elevation. Albumin is normal. Prothrombin time, prolonged in severe cases because all clotting factors except for factor 8 are produced by the liver. Anti-LKMA with hepatitis C. And then we have hepatitis markers, serology, hepatitis A markers, hepatitis A antigen and stool only, rarely used, and antibodies, IgM, recent infection, IgG, old infection. Hepatitis B markers, we have surface antigen, surface antibody, core antigen, core antibody, E antigen, and E antibody. Surface antigen, first marker of infection, it appears 6 weeks after infection, disappears after 3 to 6 months, and if it persists more than 6 months, this means chronic infection or carrier state. Then we have surface antibody. Its presence means immunity, so there's no need for vaccination. It appears in blood after 3 months, and it persists. The window gap is a period between disappearance of surface antigen and appearance of surface antibody. Then we have hepatitis core antigen, found only in hepatocytes and not in blood, so it's not important. Core antibody, we have IgM and IgG. IgM, high titer, means acute hepatitis B, and it may be positive during the window gap. Chronic hepatitis, low titer of IgM. Core antibody IgG, lifelong marker indicating past exposure to hepatitis B. It doesn't mean immunity or previous vaccination. E antigen appears shortly after surface antigen in the serum, and its persistence is indicative of active viral replication with high degree of infectivity, while E antibody indicates low infectivity. So the laboratory test, which should be ordered on screening for acute hepatitis B infection, surface antigen, IgM anti-hepatitis B core, and DNA polymerase responsible for the process of DNA replication. Hepatitis B virus DNA by PCR is the most sensitive index for viral replication. Good prognosis means negative surface antigen, negative E antigen, positive surface antibody with E antibody. Bad prognosis is the opposite. So, the use of hepatitis B virus markers in clinical practice. For acute hepatitis B, we have positive surface antigen and E antigen with positive IgM core and antibody, and negative surface antibody, E antibody, IgG antibody, while the DNA would be more than 10 power 5 copies per milliliter with elevated liver enzymes. Resolved acute hepatitis B, negative antigen, so negative surface antigen, negative E antigen, negative IgM core antibody with positive surface antibody, E antibody, and IgG core antibody, negative DNA test, and normal liver enzymes. Then we have chronic hepatitis, high replication and low replication. High replication, positive antigens, so surface and E antigens are positive, surface antibody and E antibody are negative, IgM core antibody and IgG core antibody are positive, with DNA more than 10 power 5 copies per milliliter and elevated liver enzymes, while in low replication chronic hepatitis, normal liver enzymes, hepatitis B virus DNA from 10 power 2 to 10 power 4 copies per milliliter, positive IgG core antibody, positive anti-E antibody, and positive surface antigen with negative E antigen, with negative surface antibody, with negative IgM core antibody. Vaccination means negative antigens, so surface and E antigens are negative with positive surface antibody and negative IgM or IgG or anti-E antibodies, and negative DNA with normal liver enzymes. Hepatitis C markers, diagnosis of hepatitis C, hepatitis C, IgM and IgG by ELISA and REBA. ELISA, positive after 6 weeks of infection. REBA, recombinant immunoblot assay to confirm positive anti-hepatitis C virus ELISA in patients with undetectable hepatitis C virus RNA. Number 2, hepatitis C virus RNA PCR polymerase chain reaction, positive within 2 weeks and marker for active infection. Then we have the genotype to predict the response to therapy. Genotypes 2 and 3 have better response than 1 and 4. Liver enzymes, serum albumin, prothrombin to assess chronic liver disease. Ultrasound should be ordered to assess presence or absence of cirrhosis. Portal vein diameter and size of spleen. Liver biopsy to detect chronic hepatitis activity and degree of fibrosis. Surface antigen for hepatitis B to exclude co-infection with hepatitis B. Hepatitis D markers, IgG and IgM antibodies with surface antigen for hepatitis B, which is positive. Hepatitis E markers, antibodies IgM and IgG. Then we're gonna discuss treatment. We have prevention and therapeutic treatment. Prevention, general measures, immunoglobulins and vaccines. General measures, hygienic measures, especially in hepatitis A and E because of fecal-oral transmission, with supervision of blood transfusion, especially in hepatitis C, B, and D. Immunoglobulins as soon as possible after exposure. Vaccines, for hepatitis A, Havrix. For hepatitis B, it's given 0-1-6 months, given to groups at high risk such as homosexuals, health professionals, hemodialysis patients, hemophiliacs, patients requiring repeated transfusions, and household contacts of hepatitis B virus patients. Therapeutic treatment, rest, diet. Symptomatic treatment, rest until the patient becomes clinically and biochemically free, which means bilirubin less than 1.5 milligram percentage. Diet, highly appetizing diet with increased carbohydrates. Low-fat diet preferred because it can lead to nausea and vomiting. Proteins free but should be restricted if manifestations of liver cell failure appear. Multivitamins without alcohol. Symptomatic treatment, antiemetics for nausea and vomiting, cholestyramine for itching, and treatment of complications such as acute fulminant hepatitis. Cortisone is contraindicated, but it may be indicated in a case of prolonged cholestasis, which is called Watson's syndrome. Then we have chronic hepatitis. Chronic hepatitis is defined as any hepatitis persisting for longer than 6 months. Etiology, infections B, C, and D. Immune, autoimmune or lipoid hepatitis, iatrogenic alcohol methyl dopa INH, inherited Wilson's disease, alpha-1 antitrypsin deficiency. Types, old classification, we have chronic persistent, mild form, and chronic active, which is the severe form. The chronic persistent, benign inflammatory reaction characterized by just infiltration of the portal tract by inflammatory cells without losing the architecture. Clinical picture, no cirrhosis. Liver may be mildly enlarged and tender, may be asymptomatic, accidentally discovered, or non-specific symptoms such as Fahem. Investigations, normal liver function test with elevated transaminases, biopsy to exclude chronic active hepatitis, and investigations for the cause, hepatitis markers. Treatment, because of its benign nature, treatment is not indicated, just reassurance and follow-up for 6 months. Chronic active hepatitis, clinical picture, mainly viral or autoimmune. Progression to cirrhosis is very common. We have viral and autoimmune. Viral, more common in males, asymptomatic for decades. Fatigue is a common symptom. Features of hepatitis, anorexia, jaundice, tender liver. Features of chronicity, late, liver cirrhosis, whether liver cell failure or portal hypertension. Autoimmune or lipoid hepatitis, autoimmune hepatitis, disease of unknown cause characterized by presence of chronic hepatitis with lymphoplasmacytic infiltration, hypergammaglobulinemia, and autoantibodies. More common in females, associated autoimmune antibodies may be present in Hashimoto's thyroiditis, pleurisy, polyarthritis, hemolytic anemia. Associated with HALA-B8, B14, DR3, DR4, DR3 associated with aggressive disease, and DR4 associated with extrahepatic manifestations more likely than the other types. Classification, we have 3 types, 1, 2, and 3. 1, positive antinuclear antibody and smooth muscle antibody, elevated immunoglobulin G. Classic 4 responds well to low-dose steroids. Type 2, positive liver kidney M1 antibody, or 2 or 3, typically female children and teenagers. The disease can be severe. Type 3, anti-SLA or LP, antibodies against soluble liver antigen, liver, pancreas. So if we're going to compare between the 3 types, type 1, we have antibody against smooth muscle or antinuclear antibodies. The age, median age, 30 years. Gamma globulin elevation is very high. HALA association B8, DR3, and DR4. Excellent response to steroids with progression to cirrhosis by 45%. Type 2, anti-LKM, pediatric, 2 to 14 years, rare in adults. Mild gamma globulin elevation, mild response to steroids, and HALA association B14 with DR3, and progression to cirrhosis is 80%. Type 3, anti-SLA or LP, adults, 30 to 50 years. Gamma globulin elevation is moderate, uncertain HALA association, moderate steroid response, and progression to cirrhosis is 75%. Investigation, we have biopsy, it's highly diagnostic, it can show portal tract infiltration, then bridging necrosis, then piecemeal necrosis, rosettes, and finally liver cirrhosis. Liver function test, we have SGOT and SCIAT increased by 3 to 5 folds, serum bilirubin increased, direct and indirect, alkaline phosphatase moderately elevated, albumin decreased levels, hepatitis markers for hepatitis B, C, and D, antinuclear antibody, anti-smooth muscle antibody, anti-liver kidney antibody in autoimmune hepatitis. And you need to know that in alcoholic hepatitis, AST to ALT ratio is usually 2 to 1, and the level of AST is usually less than 300. Treatment of chronic active viral hepatitis. Interferons, they are not used in recent protocols. We have alpha interferon and PEG interferon. Alpha interferon for hepatitis B, 5 million units subcutaneously 3 times per week for at least 3 months. Hepatitis C, 3 million units subcutaneously 3 times per week for at least 6 months. PEG interferon, long-acting interferon, 180 micrograms subcutaneously once per week for at least 6 months. Side effects, expensive. Initial response in half of the cases, relapse in half of the cases, influenza-like symptoms, fahem, bone marrow, and mental depression with increased incidence of hepatic inflammation, so it's not used in severe late cases. Monitoring, PCR, if no response after 3 months, stop the drug. CBC, stop the drug in cases of leukopenia or thrombocytopenia. The patient must be monitored carefully for side effects. Indications, positive RNA hepatitis C, biopsy with chronic hepatitis, compensated liver disease, and genotypes 2 and 3. Contraindications, decompensated cirrhosis, pregnancy, psychic disorders, uncontrolled diabetes, severe cardiac or pulmonary diseases, seizures, autoimmune diseases, and finally renal failure is an absolute contraindication for ribavirin. Other antiviral agents, ribavirin is contraindicated in kidney diseases or renal failure to be specific, and lamivudine added to interferon hepatitis B virus. Treatment for autoimmune hepatitis, prednisolone, first week 30 mg per day and maintenance dose 15 mg per day for 6 months to 3 years. If full remission, slow withdrawal. If no remission, add azathioprine 50 mg per day. Treatment of manifestations of liver cirrhosis, ascites, as immune suppressive drugs have no benefit at this stage. Liver transplantation may be indicated in viral and autoimmune hepatitis, but disease recurrence is frequent. Then we're gonna go for detailed treatment of hepatitis C and hepatitis B viruses. Hepatitis C treatment, screening. General treatment. Screening. Most patients with chronic hepatitis C infection are asymptomatic at time of diagnosis. Transmission risk. Advice on measures to decrease the risk of transmission to others. Diet and behaviors counseling, alcohol use, obesity, and insulin resistance. Dose adjustments of medications for drugs metabolized in liver. Vaccination against A and B to prevent co-infection. Symptomatic treatment and treatment of complications. Historical treatment. Interferon plus ribavirin for 1 to 2 days depending on the genotype and the SVR. New treatment, the cornerstone, oral DAA, direct-acting antiviral agents. Indication for treatment, all patients with chronic hepatitis C infection except with those short life expectancies. The choice of treatment depends on the genotype. Genotype 4 is the most common in Egypt. Drugs for treatment of hepatitis C, it's divided into polymerase inhibitors, sofosbuvir, NS5A inhibitors, elbasvir, lidipasvir, daclatasvir, velpatasvir, protease inhibitors, grazoprevir, and glipaprevir. Treatment for patients without cirrhosis or with compensated cirrhosis, daily fixed combination of sofosbuvir 400 mg and velpatasvir 100 mg for 12 weeks, or combination of sofosbuvir 400 mg with lidipasvir 90 mg for 12 weeks, or grazoprevir 100 mg with elbasvir 50 mg for 12 weeks, or glicaprevir 300 mg with piperacin 120 mg for 8 weeks and 12 weeks with HIV co-infection. For decompensated cirrhosis, same combinations but with adding ribavirin 600 mg for 12 weeks. So we have daily fixed combination of sofosbuvir 400 mg, velpatasvir 100 mg plus ribavirin 600 mg for 12 weeks, or sofosbuvir 400 mg with lidipasvir 90 mg and ribavirin 600 mg for 12 weeks, or sofosbuvir 400 mg with daclatasvir 60 mg plus ribavirin 60 mg for 12 weeks. Any protease inhibitor such as glicaprevir or grazoprevir or interferons are contraindicated for decompensated cirrhosis. Decompensated cirrhosis who are ribavirin ineligible, they are given combination of sofosbuvir with velpatasvir for 24 weeks with the same doses, 400 for sofu and 100 for velpa, or sofosbuvir with lidipasvir for 24 weeks, or sofosbuvir with daclatasvir for 24 weeks. Goal of therapy to eradicate hepatitis C virus RNA, which is predicted by achieving sustained virological response after 12 weeks from completion of therapy. Monitoring. During treatment, no monitoring is needed unless there is warfarin intake to monitor INR or diabetic to monitor hypoglycemia. Post-treatment, assess SVR, AST, ALT, bilirubin, CBC. Liver transplantation has declined with the DAA therapy. Patients with chronic kidney disease, ribavirin dose reduction may be required with chronic kidney disease stage 3, 4, or 5. Sofosbuvir containing regimens cleared by dialysis, so they should be administered after the session on hemodialysis days. No dose adjustment in direct-acting antivirals and other diseases of the kidney. Then we have hepatitis B virus treatment. Diagnosis: persistence of hepatitis B surface antigen for more than 6 months. General treatment the same as hepatitis C virus. Symptomatic treatment, treatment of complication, vaccination for hepatitis A and B for the fear of co-infection, dose adjustment for drugs metabolized in liver, diet and behavior counseling with transmission risk. Indications for antiviral therapy: it depends on presence or absence of cirrhosis, ALT level, and hepatitis B virus DNA levels. So, patients without cirrhosis, E antigen positive, immune active phase without cirrhosis, initiate the therapy if hepatitis B virus DNA is more than 20,000 international unit per milliliter, ALT is more than 2 times upper limit normal, ULN. Endpoint of treatment: seroconversion of the antigen into antibody. Additional factors: in immune active hepatitis B virus but with ALT less than 2 times ULN, and hepatitis B virus DNA below threshold, age more than 40, positive family history of hepatocellular carcinoma, presence of extrahepatic manifestations. And in hepatitis B and E antigen negative chronic hepatitis, the therapy is indicated in hepatitis B virus DNA more than 2000 international unit per milliliter, or ALT more than 2 times ULN, because the sustained remission is rare in absence of treatment. Endpoint of treatment is surface antigen loss. Patients with cirrhosis, acute liver failure, or decompensated cirrhosis, positive DNA regardless the ALT level. Compensated cirrhosis, hepatitis B virus DNA more than 2000 international unit per milliliter regardless of the E antigen. Other indications: patients with hepatocellular carcinoma, patients with hepatitis C co-infection. The antiviral therapies are PEG interferon 2A 180 microgram weekly. Side effects, we have previously mentioned it. Tenofovir 300 milligram daily. Side effects: nephropathy, Fanconi syndrome, osteomalacia. Intisavir 0.5 milligram daily, lactic acidosis. Lamivudine 100 milligram daily, lactic acidosis and pancreatitis. Adifovir 10 milligram daily, lactic acidosis, Fanconi syndrome. Terbivudine 60 milligram daily, lactic acidosis. Guidelines recommendations. Therapies of choice are tenofovir with intisavir because they are of low resistance, excellent efficacy and side effect profile. But we can use PEG interferon 2A as well. Treatment must be continued for several years or lifelong to achieve virological endpoints. Patients with reduced kidney function, the choice of agent depends on creatinine clearance. So if it's less than 60 milliliter per minute, tenofovir disoproxil fumarate should be avoided. If it's more than 15 milliliter per minute, we use intisavir or tenofovir alafenamide can be used. Creatinine clearance less than 15 milliliter per minute, intisavir with dose adjustment. Intisavir, tenofovir, alafenamide, and TDF, which is tenofovir disoproxil fumarate, can be used in all patients using hemodialysis. Liver transplantation. Despite the availability of effective antiviral therapy, some patients with complication need liver transplantation, especially with liver cirrhosis. So it's important to eradicate hepatitis B virus replication before transplant and to prevent reinfection after transplant. And this concludes hepatitis. Amoebic liver abscess or amoebic hepatitis, Entamoeba histolytica vegetative form reaching the liver from colon to through portal vein. Amoebic dysentery is present in only 50% of the cases. Pathogenesis: amoeba reaches liver through portal vein tributaries, leading to foci of necrosis. Contents of the abscess: necrotic tissue plus RBCs plus or minus pus cells with secondary infection. We have chocolate material or anchovy sauce. Clinical picture: history of amoebic dysentery, features of hepatitis, but there are severe toxemia, fever with rigorous toxic faces. The liver is enlarged and tender. Jaundice is usually absent. If present, it's due to obstruction of bile ducts by the abscess. Complications: spread and rupture, pericarditis, peritonitis, cutaneous amoebiasis, right pleural effusion, and lung abscess. Differential diagnosis: causes of enlarged tender liver, inflammation, all except bilharziasis and syphilis, malignancy if capsule is infiltrated, hepatic congestion and cholestasis, fever of unknown origin, and differential diagnosis of jaundice with leukocytosis such as ascending cholangitis, amoebic liver abscess, and leptospiral infection. Hepatic patient with right pleural effusion, we should suspect ascites or amoebic hepatitis. Hepatic patient with left pleural effusion, TB. Investigations: to detect amoeba, 4S, see amoebic dysentery. Liver function test, usually normal. Amoebic hepatitis is a focal lesion and elevated alkaline phosphatase. Ultrasound and aspiration of abscess. Blood picture: leukocytosis. Chest X-ray, raised right copula of diaphragm. Pleural complications may be detected. Therapeutic test: metronidazole is given and response is indicated. Treatment: medical treatment, aspiration and surgical drainage. Surgical drainage indicated in huge or multiple abscesses. Cases not responding to medical treatment and aspiration. Aspiration in cases not responding to medical treatment. And medical treatment is anti-amoebic drugs, general care, symptomatic treatment, and treatment of complications. Treatment of complications, antibiotics for secondary infections. Symptomatic treatment, analgesia, antipyretics. General care, rest, light, nutrient diet. Anti-amoebic drugs, metronidazole, 750 milligrams 3 times per day for 10 days, plus chloroquine, 250 milligrams twice per day for 3 weeks, plus lidocaine or Entocid. And this concludes the amoebic abscess.